So good afternoon, and welcome to the second CAST webinar of the 2019 to 2020 season. My name is Allison Del Causo Barons, and I am an HIV counselor at the Family Health Center of Morristown Medical Center and the chair of the Morris County Community Assistance Services Committee. Today's webinar is on mental health basics. A national survey found that on average there are 129 suicides every day, and for every suicide, 24 more people attempt suicide. That's why it's critical that everyone can recognize the signs and symptoms of suicide and are able to talk about it and ask people what they're going through. Despite the progress we have made in the past decade, the stigma associated with mental illness and suicide still exists in our community. The way we talk about mental illness and the things we express publicly through media, social media, in our homes, and in our workplaces can make a difference. Before we start, there are a few housekeeping things I would like to review. The first is that this webinar is being recorded and will be uploaded to the CAST YouTube channel. The second is that everyone is being muted, but comments and questions are welcome. Just enter them into the chat. I would now like to introduce today's presenters: Madine Despeine-Udoh, Tracy Klingener, and Al Shurdom from the Mental Health Association of Essex and Morris.
Good afternoon, and thank you for having us. Tracy, Al, and myself, we are a part of the Self-Help Advocacy and Education Department at the Mental Health Association of Essex and Morris, and we go out regularly to provide education and training to the community in hopes of giving them a better understanding of mental illness, as well as reducing stigma. Mental health problems are common, and there's a huge stigma associated with mental health problems. Many people are not well informed. Professional help is not always on hand. People often do not know how to respond, and people with a mental health problem often do not seek help. In fact, only 41% of people with a mental illness use mental health services in a given year. The World Health Organization, also known as WHO, has compared the relative impact of different illnesses across the world. And according to their data, neuropsychiatric disorders, including mental, behavioral, and neurological disorders together, rank as the biggest health problems in North America and are ahead of both cardiovascular disease and cancer. Of the various mental disorders, depression is the single biggest cause of burden. The major impact of mental illness is not so much because it causes premature death, but because it causes disability. Disability refers to the amount of disruption a health problem causes to a person. And in relation to a mental disorder or a mental illness is a diagnosable illness that affects, I'm sorry, we're having a little technical difficulties with the slide. A mental disorder is a mental illness that is a diagnosable illness that affects a person's thinking, emotional state, and behavior. It disrupts the person's ability to work, carry out daily activities, and engage in satisfying relationships. Mental illness can be more disabling than many chronic physical illnesses. For example, the disability from moderate depression is similar to the impact from relapsing multiple sclerosis, severe asthma, and chronic hepatitis C. And the disability from severe depression comparable to disability from quadriplegia. Depending on what stats you look at, 1 in 5 or 1 in 4 Americans experience a mental illness. 1 in 25 Americans live with a serious mental illness. Half of all mental health disorders show signs before a person turns 14 years old and 3/4 by the age of 24. When mental disorders start at this stage, they can affect a young person's education, movement into adult occupational roles, forming a key social relationship, and the establishment of health habits. Consequently, mental disorders can cause disability across a person's lifespan, and that's why early intervention is key and so important. It's important to detect problems early to ensure that persons or individuals is properly treated and supported. Mental illness is real, and recovery is possible. Recovery is the process in which people are able to live, work, learn, and participate fully in their communities For some, this is the ability to live a fulfilling and productive life despite a disability. And for others, recovery implies the reduction or complete remission of symptoms. Of all the mental illnesses, anxiety disorder is the most common. And as you can see in the percentage columns, they do not add up. And that's because many individuals have comorbidity, which is people suffer from more than one mental disorder in a given year. In fact, 45% meet the criteria for 2 or more disorders. Mental illness can be mild, moderate, or severe. About 6% of adults, which is 1 in 17, suffer from serious mental illness, which means within a given year, 3 months out of that year, they're unable to carry out normal daily activities, engage in satisfying relationships, and work.
Hi, everybody. This is Al. So what we are going to do right now is I wanted to focus on the first 3 in particular because we are going to discuss anxiety and depression in a little more detail for the next couple slides. But I wanted you to take note of the first 3 diagnoses on that chart. I believe it's inadvertent, but it does somehow provide a teachable moment here because that kind of flows like inadvertently like a flow chart. Anxiety and depression all too often are a package deal. And then, sadly, people turn to substance use to call what we call in the field, to do what we call in the field self-medicate. So that's, again, I don't believe that was done purposely, but it did happen to lay out that way. So again, we're going to focus on anxiety disorder and depression disorder for the next couple slides so you can get familiar with the signs and symptoms and what to look for, and then we will move on from there. So first, we're going to start with depression. Again, when we talk about pretty much every mental illness across the board, with the exception of PTSD, we talk about duration and severity, and that the rule of thumb on that is 2 weeks or more, and if it affects a person's ability to work, carry out daily activities, engage in satisfying relationships. You're going to see that redundancy in these slides because that is essentially the litmus test. Once it begins to affect these aspects of an individual's life, now we're talking about we're in that red zone, right? So. Moreover, emotions, thinking, behavior, and physical well-being are impacted as well when we deal with depression. All right. If there's any questions, please feel free to chat them, and I will answer them in real time as best I can. Okay. Moving on, signs and symptoms of depression. We have the emotional side: sadness, anxiety, feelings of helplessness, hopelessness, thoughts. Folks are very pessimistic. They tend to believe that others see them in a negative light. And then, of course, thoughts of death and suicide, because depression, of course, is a huge impetus towards suicide attempts. Okay. And more signs. We have the behavioral. We have crying spells, loss of interest, loss of motivation. Of course, turning to drugs and alcohol, as I shared in that first slide that we saw with the flow chart, the inadvertent flow chart. And then we have the physical: fatigue, lack of energy, hyposomnia, hypersomnia, overeating, loss of appetite, and it can affect us in the physical manifestations through headaches and irregular menstrual cycles for women, and unexplained aches and pains as well. So now, quickly, we just covered depression. Now we're going to talk about anxiety. Clearly, I am doing a webinar for my first time, speaking to people whom I never met, so I am a little anxious, but that does not facilitate an anxiety disorder. Again, we talk about duration and severity. 2 weeks or more when it affects a person's ability to work, carry out daily activities, or engage in satisfying relationships. And here are the signs and symptoms when we talk about anxiety. And you're going to see many of these symptoms mimic that of a cardiac episode, right? We have the pounding heart, the chest pains, arm pains, fast breathing, shortness of breath that can easily be mistaken for a cardiac episode when it could in fact be anxiety. The median age of onset for an anxiety disorder is 11 years old, and 18.1 because of comorbidities. Some people have more than one anxiety disorder. And anxiety disorders commonly co-occur with mood disorders and substance use disorders, and it's common for people with anxiety disorders to try to self-medicate with alcohol and other drugs to help cope. In fact, alcohol and other drugs can lead to increased anxiety. And then more gastrointestinal symptoms. You see the choking, dry mouth, stomach, and the musculoskeletal. So not only can it mimic that of a cardiac episode, but it can also mimic that of the flu as well. Okay?
And many mental illnesses show up as physical illnesses, so that's why a lot of times people go to their primary care doctor first because they think it's a medical issue, when many times signs and symptoms of a mental illness can manifest physically.
That's right. Okay, we're moving right along. So quickly, I want to talk about some risk factors for depression and anxiety. We'll get to this slide momentarily, but we're talking about distressing and uncontrollable events can be a risk factor. Stressful and traumatic events, obviously a difficult childhood, a history of childhood anxiety, ongoing stress and anxiety, another mental illness, of course, previous episode of depression or anxieties. It could be in the gene pool as well, and a more sensitive emotional nature could be a risk factor. And then more signs and symptoms of anxiety. We have the psychological, unrealistic or excessive fears, mind racing or going blank, irritability, fatigue, sleep disturbances, or vivid dreams. And then behavioral, avoidance of the situations that could have caused the stress and the trauma and the anxiety. Like, for example, if you were in a car accident, it might be days, weeks until you get back into that car. Obsessive compulsive behavior and distresses in social situations, or you can develop a phobic behavior. In our community, agoraphobia is the most prominent. Folks do not like to leave their safe space and go out into the world because that's where the bad things happen, in particular when we're talking about anxiety-inducing events or trauma. More risk factors: illness that is life-threatening, chronic, or associated with pain, medical conditions, side effects of medication, recent childbirth or postpartum depression, and anxiety, premenstrual changes in hormone levels, like menopause, for example, lack of exposure to bright light in winter, seasonal affective disorder, otherwise known as, and a chemical neurotransmitter imbalance that can cause depression and anxiety as well, and substance misuse, or when we talk about intoxication, we talk about withdrawal symptoms, right? When an individual is going through withdrawal, it could absolutely cause anxiety among other conditions as well. Okay, so we talked about depression and anxiety, and we did an overview, risk factors, and signs and symptoms. So now we are going to talk about the impact of mental illness, and Madine kind of touched on this earlier, but we have to reiterate it because, again, I talked about this being a litmus test. When we talk about a disability, we refer to the amount of disruption a health problem causes a person's ability to work, carry out daily activities, engage in satisfying relationships. And then we want to present it in a different context where mental illness can be more disabling than many chronic physical illnesses. And I'm going to hand it over to Tracy to talk about her casserole effect, the disability, and that applies to the physical illnesses that we give much more in terms of empathy and compassion than we do somebody who is experiencing mental illness. But just to note that the disability for moderate depression is similar to the impact of relapsing MS, severe asthma, or chronic Hep B, and the disability from severe depression is comparable to the disability from quadriplegia. So this is just a different context. And the casserole effect, Tracy?
So the casserole effect, I feel like that dates me. I'm 40 years old. I gave a training not too long ago, and someone chuckled, like casserole. So we'll say dinner. Many times if someone's diagnosed, a neighbor or a friend with cancer, you might bring them dinner. If someone's diagnosed with major depressive disorder, we have that thought of, well, pull yourself up by the bootstraps. You need to get out of bed. You have a family to take care of. What's wrong with you? And mental illness is the only illness that we blame the person for, and we treat it very differently than physical illnesses, which is why we're showing you this slide.
Right, absolutely. Okay, so we talked about the impact. Now, politically correct, those are two words that people don't tend these days to want to hear, but we are politically correct in this world, and proudly so, and with good reason. If I were to call John or Jane Doe a schizophrenic, we would now not care that Jane is a wonderful chef, John is a wonderful athlete. Whatever the case may be, we stop caring about that because we only see Jane and John as schizophrenic. So we try to steer clear of icks in our world, and that applies to alcoholic and addict. Now, that doesn't mean any disrespect to Alcoholics Anonymous or Narcotics Anonymous, who do use the icks, and they do wonderful work. This is context, and we're taking on this huge undertaking of eliminating stigma as it pertains to mental illness, and the language we use is part of that solution. So we say things like person with schizophrenia as opposed to schizophrenic. We say person struggling with substance abuse, not an alcoholic or an addict. And just like we wouldn't call somebody with leukemia a leukemic, that's a good rule of thumb to remember. We don't want to put those labels on an individual because we don't want the illness to be the defining feature of the individual. So we want to make sure that we know that a person is like the proverbial onion, many layers, and we want to appreciate those layers and not see Jane the schizophrenic, John the addict, okay? So, more language, understanding the language of suicide. Now, we avoid commit because of connotation. Criminals commit crimes, murderers commit murder, right? So we stay clear of commit suicide. Instead, we would say died by suicide. We don't want to victimize the individual who is attempting suicide, so we say person who died by suicide as opposed to saying a victim, because we don't look at suicide in our context, in our world, as good or bad. We look at it as a cry for help more often than not. So we don't want to label the individual a victim or use any kind of negative words that can connote persons who. So we use died by suicide, person who died by suicide, and instead of completed suicide, which is the flip side of commit, because completed has a positive connotation, we say attempt suicide or died by suicide again. So the words we use are very important.
You want to read that question?
Sure. So the question is, I spoke with someone recently who has been diagnosed with anxiety and seems to feel like there is legitimate anxiety and illegitimate anxiety, with the difference being legitimate anxiety has obvious physical manifestations, i.e. uncontrollable panic attacks, for instance, whereas illegitimate anxiety happens in his own mind and therefore should be able to be controlled. Since he doesn't have quote-unquote panic attacks, he doesn't feel like his anxiety is legitimate. What would you say to reduce the stigma around anxiety that does not necessarily have physical signs, but instead interferes with other aspects of functioning, such as their ability to work, process information, interact socially?
That is a disorder.
What's that?
That would be considered a disorder if it's affecting his ability to work,
yeah,
process information, interact socially. That would be considered a disorder because it becomes disabling.
Right. So what we would say to an individual like that, Allison, and thanks for the question, we would say that we would implore him, that we would remind that individual that this is a very common diagnosed illness, and that there's nothing to be ashamed of here, and to set up these own kind of, and that's something we see very common. We see the prejudices around mental illness. There's generational, there is cultural, and then there's the individual with his own self-bias. He's like, this individual has set up and constructed barriers around what is and what is not. So we would appeal to his, just to explain to him that all these symptoms based on the litmus test that we showed, the work, carry out daily activities, or engage in satisfying relationships, are being impacted. Therefore, that this could very well be an anxiety disorder, and there's nothing to be ashamed of, or there's nothing to be fearful of, that we can get through this, and by using compassion and empathy and showing the individual that there are people who have been there, gone through it, and come out the other side, hopefully we can appeal to his better nature and get him to seek treatment.
And I think too, also, nowadays people use anxiety so frequently. Oh, I have anxiety. So do I. But being anxious is different than being diagnosed with an anxiety disorder. Just like people throw around the word I'm depressed, but that's different than being diagnosed with major depressive disorder.
Right. Thanks for the question. Any others before we move on? Okay. All right. And I hand it over to Tracy.
So we're going to be talking about risk factors for suicide. Just because an individual may have any one of these risk factors, it does not mean that they will attempt or die by suicide. It just puts them at a greater risk. Just like if you have risk factors for heart disease, you're more likely to be diagnosed with heart disease, but it doesn't mean that you will be diagnosed with heart disease. So when we're talking about gender, males attempt at a higher risk than females. die at a higher risk, than females, usually because they use lethal means. Age, we're talking about the younger population as well as seniors and older adults. When we're talking about youth, the highest range used to be between the ages of 19 and 24, and now they find that it's higher in 10 to 13-year-olds, and they think that has to do with bullying, social media. There was actually a study that showed that 48% of youth who go on social media more than 5 hours a day have at least one risk factor for suicide. Another risk factor is chronic physical illnesses, mental illness, use of alcohol or other substances because it lowers your inhibition, less social support. My colleague Al always gets a kick out of this, but studies have shown that males who are not married have a higher risk of suicide than men who are married.
Married men have a higher rate of homicide, I'm certain of it.
Another risk factor is previous attempt in an organized plan. Previous attempt is actually the #1 risk factor for suicide. New Jersey actually has one of the lowest suicide rates when we're talking about youth. And I think the average is 82. So that's actually 4.5, every 4.5 days a youth dies by suicide. But it's one of the lowest states where Alaska and Montana actually have the highest rates of youth suicide. And that could be because New Jersey, except if you live where I live in Essex County, you have a lot of access to services, and there's a higher population rate than there would be in Montana and Alaska. So when we're talking about warning signs, the one that we think about the most is threatening to harm or kill oneself. And really, you want to take notice to any change in behavior. So if someone isn't showering and they used to come to work, with makeup on, hair done, and it's a pattern that you're seeing, you want to take notice of that. If they're calling out of work a lot and they never called out before, you want to take notice of that. So it's really, we want to focus on that change in behavior. Other warning signs: seeking access to means, talking or writing about it, feeling hopelessness, worthlessness, acting reckless, feeling trapped, increased alcohol or drug use to self-medicate, withdrawing from family, friends, or society, demonstrating rage and anger, appearing agitated, having a dramatic change in mood. And that doesn't necessarily mean from going to happy to sad. It could also be going from sad to happy because they finally found a way out of that feeling of hopelessness and helplessness. And also one that isn't on there is giving away your prized possessions. So talking to a person about suicide. So really it's about acknowledging that change in behavior, right? So you notice a change in behavior, you address it with the person. So I've noticed X, Y, and Z, a change in your behavior. And I think it's really important when you talk to this individual to give specific examples about the change in behavior that you've seen. I've been feeling concerned about you lately. I wanted to check in because you haven't seemed like yourself. I noticed that, while you were at work, you're usually chatty and talking to people, and now you're really just staying to yourself and not talking to your other coworkers. And you really, when you do this, you really want to start with I statements, even the first way to start a conversation. I have been feeling concerned about you lately. Questions you could ask: when did you begin feeling like this? Did something happen? How can I best support you right now? Have you thought about getting help? What you could say that helps: you are not alone and I am here for you, I feel like are the two most powerful sentences you could say to anyone, especially when they are feeling suicidal. The support that you give to someone even if it's just checking in on that person daily, can mean so much to them. I actually had a seizure almost 6 months ago, and I was feeling extremely down, and I was actually having suicidal thoughts. And you might say, oh, well, you're in the mental health field, you should know what to do. But when you have that feeling of hopelessness and helplessness, you feel like there is no way out. And, you know, my friends and my family really, you know, gave me that support every day, checked in with me, and let me know that they were there for me constantly.
There's one thing that I want to stress that Tracy brought up, which I think is very important. I think our natural inclination is to want to say the right thing and, you know, provide, you know, healing, because that's what we are, you know, exactly right. And that last one right there, to say, I'm not sure, I don't know what to do here, but I'm here, that's essentially, that's very poignant, because many of us won't know what to do in real time, you know, unless you're a trained professional. If this is a loved one or someone you care about, you might not know what to do with that, because it might be so overwhelming to you as well. But it's very important to remember that, you know, we're building that connection with that human, with that individual that's in pain, that's in crisis, and saying something like, I don't know what to do, but I'm here, is an especially poignant gesture.
Absolutely. So asking the question, listen, I've been in the field a very long time, 20 years. Madine has been in the field a long time before that. I don't know if I stress that, long time. And we still get anxiety asking the question, because you have someone's life in your hands. And it's definitely anxiety provoking. You want to make sure you say the right thing. You want to make sure you do the right thing. And it could definitely cause anxiety.
And you always want to make sure you, when you're asking the right questions, you gather as much information as possible, because you may be on the phone with that individual and talking to them, or you may not know where they're at, and you want to just make sure you get as much information, one being means, if they have a way to do it, so that you can get them the proper help as soon as possible.
Right. And Tracy dated herself with the casserole effect. I'm going to date myself. I always say this, you try to keep it light, but when we are in the presence of somebody in crisis, suicidal crisis, I always say we want to be Fonzie in that moment in time, right? We need to stay, even though in the inside we may be doing flips and jumping jacks, externally we want to be calm, cool, and collected, and be mindful of our tone, inflection, and rate of our voice, because it's not unlike what, if you've ever been around a child learning how to walk, if they trip and fall, they look to the parent. If the parent is laughing, the child will laugh. If the parent is upset and fearful, then the child will cry. So I don't want to, I hope you understand, I'm not trying to liken somebody in crisis to a child, but I'm just saying the scenarios are very similar in the sense that they will take, when somebody's in crisis, they will take the cue of the individual that is in the room with them. So if you are calm, cool, and collected, you will see them de-escalate right before your eyes. I promise you that is from experience. I've seen it and even heard it when I was on the phone with the individual as well.
Also, too, it's how you ask the question.
Yep.
So, are you having thoughts of suicide is very different than you saying, well, you're not thinking of killing yourself, are you? So things to remember. I think one of the biggest myths when we talk about suicide is if you bring it up, you're going to put that idea in their head. Many times it's a relief for that person to talk about how they're feeling and what they're feeling. One more thing to mention before we go on, you know, if someone does say yes, you want to ask these follow-up questions about, have you decided, do you have a plan, have you collected those things to carry out that plan? Even if the person does not have a plan, it doesn't make that threat any less real, and that person is still in crisis. And two other risk factors, if they've been using alcohol or other drugs, because that could lower their inhibition. And as I said earlier, the #1 risk factor for suicide is a previous attempt in the past. So when we talk about it may be a relief for that person, one, because
someone actually notices them. I actually gave a presentation on suicide to cafeteria staff, and a young lady raised her hand and said, well, this is all well and good. However, we're not allowed to talk to the students, which I was baffled about, because when I was in high school way back when, I used to stop and get 2 chocolate chip bagels with butter. 2, that's right, I don't think I've had a bagel at all in the last 4 months, so I really should have cherished that time. But I used to have one of them for breakfast and sit in the cafeteria and talk to the cafeteria staff. And what I said to that individual was that even a smile shows someone that you see them. So you also want to remember that it's about them and not us. And I think adults do that a lot, especially when they're talking to youth. And their experience is very different than our experience. And you want to identify people's past supports. I love to have clients write down on a piece of paper who their supports are in their life and keep it with them. So if they ever feel that they're alone, they're able to pull out that piece of paper and look to see who they have in their life that they can contact. Involve them in the decision-making process. This can offer some control when they feel that all control is lost. And they need empathy, and we want to take the person seriously. And especially when we're talking about youth, you know, parents might say, oh, well, stop being dramatic. And really, we have to listen to that person, even if what we think that they're saying is not serious or important. We have to take them seriously. And everyone, we can't judge people's feelings, and everyone's allowed to have their own feeling and be affected by their own situation. So we don't want to leave an actively suicidal person alone. Even if you say, you know, sit here, I'm going to get help, you never want to leave them alone or use guilt to prevent them from attempting suicide. Agree to keep their plan a secret or make promises you can't keep. Argue with the person, act shocked, give advice, and dismiss the problem or emotion. So when we're talking about keeping their plan a secret, you know, many times people don't want that individual to get mad at them or get them in trouble, but we have to realize that you could be potentially saving someone's life. So even if they never talk to you again, you did the right thing by getting help for that individual. So what not to say? Don't worry, everything will be all right. By next week, you'll forget about it. This is nothing. Cheer up. You have so much to be thankful for. Think about how your family would feel if you killed yourself. Suicide is for cowards, and I know you're not a coward. Other things that I've heard is, you know, like I said, I had a seizure a few months ago, and I remember my friend said to me, well, things could always be worse. And absolutely, things could always be 1,000 times worse. But for me in that situation, it was pretty crappy for me in the moment. And also too, my mom being my mom, and she's a wonderful person, something that she says to me all the time is, you have to think positive, which is absolutely true, but sometimes it's not the easiest thing to do, and it could be sometimes very frustrating when someone feels that overwhelming feeling of hopelessness and worthlessness.
So the goal is not to imply or put in your own personal judgments and beliefs in that situation. One of the biggest things that we hear in the faith community is when someone is actively suicidal and they go to someone, that individual from their church or congregation says, you will go to hell, what would the Lord do or feel, like bring in their own faith into the situation when it has nothing to do with their faith, and almost put in a level of guilt onto that individual who is crying out for help.
Right. And that last one I actually put on there because I have a friend who confronted a friend who was suicidal and used that line and is convinced that that was the right thing to say. I've been trying to move him off of that for years now, and he won't come off it because in his mind it was successful, and he said the right things because he stopped that individual from attempting suicide in that moment in time. wonderful, that's great. But the reason why we don't use shame or say things like suicide's for cowards, you're not a coward, is that you may succeed in real time and stop that suicide attempt. But a week goes by, 2 weeks go by, and the symptoms persist. That individual most likely will not seek you out again. Moreover, they won't seek out help at all because now you've taught them that what they are feeling is something to be shameful of. So we don't use shame, guilt, when we are trying to talk somebody down, quote unquote. We use compassion and empathy, not sympathy, folks. Sympathy can blow up in your face. Even though your intentions might be wonderful and pure, you may inadvertently diminish their plight, and you don't want to do that by likening it to something that you've experienced or someone who's gone through. It may not be the same thing. So empathy is the safer play, I assure you, a lesson learned the hard way. So stay with empathy and compassion, and be mindful of your tone, inflection, and rate, and you should be successful.
And if you're not sure where to go or how to reach out to get some help or services for that individual, you can always call the National Suicide Prevention Lifeline. They operate 24 hours a day, 7 days a week, and they're there to provide support for any and everyone who may be struggling or in the midst of a crisis, a suicidal crisis. And there's also the crisis text line, which a lot of youth seem to like the most because they are technically savvy. They prefer to text rather than to pick up the phone and talk to someone. So this way they are able to engage and talk to someone via text messaging. And this is the contact number and how to go about reaching out to that service. And if all else fails, you can always call our, within the county, we have St. Clair's, Chilton Memorial, as well as Morristown Memorial, their psychiatric emergency screening center for help and support. Those are the listed numbers for that area. And if all else fair, if you don't know where to reach out to and get support and services, you can always call us at the Mental Health Association of Essex and Morris. We have an information and referral service. If someone's looking for a therapist, a day program, a psychiatrist, we're able to match you, give you some references or recommendations that you can tap into and utilize. And we also provide wellness programs here because we know socialization is a big issue with a lot of the people that we work with. So we have some social groups that are free that people can take part in. And we also have a warm line that operates all year round between the hours of 5 p.m. and 10 p.m., where individuals can just call in and just talk to someone about any and everything. It's not a crisis line, it's a warm line. So they talk about, things from like baseball games to, how it is at home, and also use that line to get support and services. And that number is 877-760-4987. We actually have 3 lines, and we're going to type it up in the chat box. 866-445-3902 or 800-381-2059. We also do a mental health first aid class, which is an 8-hour curriculum class. It's an evidence-based course that's nationally recognized, where we go over all the core mental illnesses as well as how to respond to someone who is in a mental health crisis, and the resources and services that are available for individuals to tap into to get that individual help. And if you are interested in that, you can always reach out to us and we can teach that class to a group, or you can take part in one of the groups that we're having. And we also have a directory of basic support services, which lists all the resources within the county, whether it's housing, mental health services, financial services, crisis intervention services, and some on a state level that individuals can reach out to, that you can just pull out and give contact information on or phone numbers on, so that they can tap into to get the services and the help that they need as well. And that's all we have for now. If you have any questions, right now is the time to ask.
Okay. Well, it was wonderful. This was a wonderful experience. We are here if you need us. And anything else to add, ladies?
No, thank you for having us.
Yeah, that's it.
Thank you very much, guys. So the YouTube channel will have this up. I know that it was like a different format for you, so thank you for participating in the new format. I know it's different because you can't see everybody's faces, but sometimes when there's no questions, it means that you did a good job of answering them throughout the presentation.
We've never done it this way before.
So thank you for participating in our format, and for being available for us today.
Absolutely. And Allison, if you want more information about mental health first aid, just let us know. We can teach a class where it's an 8-hour course, and they get certified as a mental health first aider for 3 years.
Yeah. So certification course.
Yeah, and it's a go ahead.
What I'd like you to do is, if you can send me the information on it, when I send out the link for the YouTube upload, I can include that information too, so that if agencies also wanted to schedule you to come out and do that longer piece with them, that they can contact you directly, because I think it's a good thing for agencies to do.
Awesome. Thank you so much.
All right. Thank you. Again, this is a last chance for questions. All right. Again, put them in the chat if you have them. All right. Thank you so much. I really appreciate it. And we at CAS really appreciate it. So thank you.
Thank you.
Thank you, everybody.
Have a good day, everybody.
You too.
I'll just let you hang in.